I'm going to welcome Professor Philip Evans, who's come again from the Exeter team, works with Sir Dennis Pereira-Gray, and Kate Sidaway is the other person we need to mention who's involved in your team.
Kate Sidaway, yes.
Yeah, that's right. Yeah. So welcome, and you're a national research lead, of course, representing primary care with the NIHR. So you have that research background and experience, which I'd probably expect being in Sir Dennis's practice, which is good.
It's rubbed off on me.
Yeah. Now, we are a practice of some 17,000 patients, I think, we are looking at continuity. Obviously, that's one of the things we'll now do. It would be really nice to know where we are. But the question really arises, do we need to actually know where we are? Do we need to be measuring it when actually we could just get on and do it? You know?
Well, that's a very good question, Mark, and thanks, by the way, for inviting me onto this webinar. And I think that's a really important question to get at the beginning. And the approach we've very much taken with our project is exactly that if you ask GPs about continuity, we get a whole range of results. But what we have found is GPs don't always know exactly what their levels of continuity are. Yeah. And I think that's really important. So we've taken the principle, I've got a few slides here just to show you, but we've taken the principle, if you don't measure it, you can't manage it, which is really one of the main planks of management theory from Drucker in the States a long time ago, but it still rings true today. And it's very much the case, I think, you've got to know where you are to see where you want to go, as we've been hearing it from Joe just now, really. So measurement of continuity in our mind was probably the most important part of the process, to take a baseline measure of continuity and then to move forward with all the things that the practice may wish to do to improve continuity. But if you don't know where you are at the beginning, then you can't move forward. So that's the approach that we've taken all the way through, and with our pilot sites, we're starting to do that and feed back their results to them.
Okay, so it sounds like I do need to know where I am, which is just as well, because I'm quite interested, and in fact I'm intrigued with my practice to see where I am at. You know, I've got 8 partners in the practice. We've got salaried doctors, we've got GP registrars, and we use the EMIS system. So is there a simple measure of impact that we could use?
Yeah, I mean, the simple measure that we've developed in St Leonard's, I'll just go on to in a second, but it's called the SLIC, and you'll have heard of that. And we've published it earlier on this year with Kate Sidaway-Lee, which was great, and our team in Exeter. And this is actually not a new thing we've developed. In fact, it's a system that we've been using in our practice for over 30 to 40 years, just well before I started as a GP over 30 years ago. So the St Leonard's Index of Continuity of Care, you can see on the slide, this is the simple system and the simple metric that we're using, which we think resonates very well with GPs, and certainly when we're presenting it back to practices, we get a real feel for GPs saying, or as you were saying, the face validity, but it sort of resonates. It resonates with them. So in practices, as you were saying earlier, most practices divide the workload up either into personal lists or into GP groups of patients who are with a named and accountable GP. And the SLIC is very simply the percentage of face-to-face GP appointments, as you can see on the slide there, that are with the patient's group of patients' own named or accountable GP rather than with other GPs. So we took an example of, Dr. A, fictional Dr. A. If you look at all the appointments with Dr. A and then divide that by all the appointments that are with any GP in the practice, including Dr. A, then you very simply get the SLIC figure. The next slide is quite helpful because that just shows you a sort of worked example. So we have Dr. A, she is a named and accountable GP for a group of patients. That list of patients generates, say, 2,000 consultations during a set time period, and we usually go for a year or something similar. Yeah. And of those 2,000 consultations, Dr. A does 1,000 of those face-to-face. So in a simple calculation, you can see that the SLIC for Dr. A's list is 50%, 1,000 over 2,000. So that's perhaps the premier metric that we use for continuity. It's patient-facing, and it's a very important management tool. We might go on later to talk about the management implications of measuring that regularly, and I can show you some actual figures in a second of the SLIC figures. Yep. The other metric that we're using and the measurement tool that we're using is a slightly different take on continuity, and this is actually a doctor-facing take on continuity. continuity, which is called the own patient ratio. And as you can see from the slide there, the own patient ratio, or the OPR, again, a very simple measure, is the percentage of the face-to-face appointments of any GP that are with their own patients rather than with other GPs' patients. So if you do a surgery of 12 patients and 6 of them are on your list, then you'll have an OPR of 50%. So it's very much calculated, as you can see there, all the appointments with Dr. A's patients over all the appointments with any patient that he or she is seeing gives you the own patient ratio. So that's those two measures. Again, we've got a very quick worked example. So Dr. A in a whole year does 5,000 face-to-face consultations, and for them, 1,000 of those are with patients for whom they're the named and accountable GP. Yeah. So the OPR, which again resonates with some doctors, it is 20%. So they're seeing. They've got, in each consultation, each surgery, on average, 20% of their patients would be off their own list, or they would be the named and accountable GP. And if people are interested in that, there's lots more detail in our paper that was published in the BJGP earlier on this year, and you can see the reference at the bottom of the screen there. But I thought it's always useful in these sort of cases to show you some real worked examples, as Dennis was alluding to earlier. And this is the graph that we published in the paper, which we published earlier on this year. And each of the lines are individual doctors, and this is over a 2-year period. And so we have the lists, the practice list is split into personal lists, as Dennis was explaining earlier. And you can see several things about this. One, the SLIC is the y-axis on the left-hand side, and then obviously time is going across the bottom. And several things, I think, are obvious. One is it's very variable, and as Dennis was again alluding to earlier, GPs won't be in the practice some days, some weeks. They may be on holiday, have annual leave, study leave, sick leave, or whatever. And also most staff, well, in fact, all staff in our practice were part-time. Yeah. So all the GPs were part-time. So this shows what's achievable in the sense that you can achieve these sort of levels. They do vary, of course, as we're saying, according to holidays and other things during the year. So, yeah. But the black line, the black dotted line in the middle is probably the most important thing, and that's actually what's achievable within the practice overall. So that's a very important metric that, again, we use. And these are the sorts of figures, I think I'll mention in a second, that we feed back to practices. The next slide is, again, a really important slide. So looking at the SLIC, in other words, the chance of an individual GP seeing their own patient when they come into the surgery, this is a very important measure that we've done here, split by age bands, and it relates to the discussion that you were having earlier about for whom is continuity important and for whom is it achievable. And what we found in our practice, for example, as Dennis was saying earlier, to the right of that, the age group, so with older patients, we're achieving over 66% in the 65 and over age group. They're the group with multimorbidity who consult frequently and for whom continuity is particularly important. Yeah. But our approach very much in our pilots has been continuity counts across the board. So we were perhaps surprised, in fact, to see that you can maintain very good levels of continuity, even with those traditional groups who don't necessarily expect to have continuity in teenagers or young adults. And you can see those figures even in 30s or 40%. So 1 in 3 times they could see their own doctor. And we think it's really important to get that continuity in early so that you get used to your doctor. So when the times matter and you need to either disclose something very personal or there are diagnostic issues, you know the doctor and you're able to relate to them, as we were hearing earlier. So that's probably the most important thing. It is achievable. The SLIC is a simple way of managing it. There are other measures of continuity, which, as you know, it's quite a complex area. So we've attempted through the SLIC to very much simplify it for the working GP, and that's the sort of approach we've taken. And there are many papers published on how you measure continuity. Perhaps the most widely used one up till now has been the Usual Provider of Care Index, or the UPC. This is an alternative to the SLIC. It gives a very different take on continuity, actually. And as you can see from the slide, it's the proportion of appointments for each patient that are with the most frequent provider, irrespective of who that provider is. It could be a registrar, it could be a locum, could be a nurse, or could be any other health professional in the practice. And this has been used individually, but gives you a figure for each patient. So it's a patient level metric. But there are a significant number of limitations, we think, from the UPC, which, when you relate it to the SLIC, some of those we think are quite important. It only applies if you come 2 or more times in the time period. So you have to have at least two or more consultations, which the SLIC you don't have to have there. And hence it needs a longer time frame to be meaningful, as you can see from the slide there. For those people who are interested in these things, we've got into some very detailed comparisons in the paper, comparing the one with the other. But both are available and both are in the RCGP continuity toolkit. So it's a useful way. We're putting both out there for practices to look at.
That's great. That's really, really helpful. And I think we have to say that the SLIC is very much the exeter-based, and actually the programme that we're running, the Look at Continuity of Care, mostly uses the UPC. But there are definite advantages and disadvantages. And of course, SLIC is where you've got a named doctor, and the UPC is where you haven't got a named doctor. So there's that. Can we combine the two in our systems in some way?
Well, we don't normally recommend it. You can in theory and certainly in research. We did in our study, for example, we compared the SLIC results to the UPC. But I think probably they're different aspects of continuity. And I think it's what fits with the practice. And what's more importantly, I think what you're measuring. Because, if you're measuring, as we were saying earlier, every practice has a list of named and accountable GPs. Why don't we use that as a good basis for the analysis? So that's why we think the SLIC is probably more useful and more practical in a day-to-day practice setting. Also, often the UPC only takes a sample of patients, so you may have 100 patients or something that you can manage to do the analysis on, which may not give quite the whole picture. So we try and keep them separate and do them separately.
Yeah. So people can use both if they haven't got the name. Yeah. And also there's the issue of continuity with other members of staff, because I suppose that's a point that we could bring up. And I think the plan is to get these accessible on the web eventually, so that people can do that. It might be one of the outcomes of the Health Foundation project.
Yeah, that'd be great.
We've got a question come in. It says here, how can we balance continuity and access? Many of our patients would prefer to see someone who is not their usual GP if they can see them sooner. How forceful are you with asking the patients to book with their usual GP?
Well, I think there's several aspects to that. I mean, we know it's a trade-off, as Dennis was saying earlier, between continuity and access. But I think it's not exclusively one or the other. I think it's one of the key messages we've found when we've been dealing with this. So we shouldn't throw the continuity baby out with the access bathwater. And I think that's the most important message that we've been giving. And practices value continuity, patients value continuity, but clearly patients value access as well. And we know that patients will trade off. The research shows that they'll trade off a slight delay in access to encourage continuity. And I think each practice needs to look at what that delay might be, and measuring the delay in the system. In fact, measuring a lot of factors in the system we think is very, very important. The other aspect of that is the approach of the practice, as you were saying, to continuity. We think there aren't many practices who have a very strict personal list system. We think there's a very small proportion of practices that run that way. Most practices have a practice ethos that will encourage continuity. So I think what we're seeing, and the evidence from the research studies, is practices that encourage continuity and also encourage patients to change. But on the whole, patients will tend to follow the doctor that they're who's responsible for them. So I think it's a difficult balance. Each practice has to get it right, but don't forget continuity. I think when you're looking at how you provide access. And it's been a struggle for all of us as GPs over all these years, decades. How does each practice, we've always tweaked our systems, but now with a whole plethora of new access arrangements. But you can get continuity through the new access arrangements as well. So I think just remember that you can do both, but you've got to get the balance right. And what we feel is most important is to measure both. Yeah. Measure access, but most importantly from our point of view, to measure continuity.
Yep. So the message is coming over here is you can have continuity when you need a good access, and you can do it with part-time GPs and in a busy NHS. So
yes, you do. I mean, our practice figures that were published, we have same-day triage, we have nurse-led clinics, etc., etc. So those are achievable. With all of those things going on, you can still get continuity.
Yeah, so which is really good. Yeah. We've got another question here which says, outcome measures seem to focus on consultation frequency and patterns. Could we incorporate the relationship aspects of continuity into usual measures? Looking beyond longitudinal continuity into relational continuity. you might be able to
Well,
expand
that's a
on that.
really important question, actually, and I think it very much reflects on what Dennis was saying earlier about the behavioural interaction between the doctor and the patient. What we're talking about are very simple metrics about, measuring who sees whom. I think the next step, and hopefully the Health Foundation will do this, and we're beginning to do it a little bit in our pilot as well, will be to explore the depth of that relationship and what that relationship means to the patient and to the doctor as well. So we're doing some questionnaires with patients as they come out of the doctor and relating that to continuity, looking at what their perception was of the doctor during that consultation, and using some well-validated questionnaires that look, for example, one that looks at the responsiveness of the doctor to the patient. So I think that's a really important piece of research that needs to be done. And then those behavioural or relational indicators could be built into some model. But at the moment, we don't have outcome measures for continuity. So we're starting small, and I think working up to the more complex things later. Really.
Yeah, and the message here is that not just measuring, it's about asking GPs, it's about asking patients, isn't it? And it's that relationship that's the important thing from that point of view. I think that's a key point. I mean, cost is that an issue here? I mean,
cost, yeah. I mean, practices are used to dealing with data and looking at their own data and getting benchmarking data from other areas. We've in our 5 practices that we're working on, Kate Sidaway-Lee's done some excellent work on this, but we've trained the staff themselves to do that. So we think it takes between 1 and 2 hours a month of admin time or secretarial time. It's not a high-level task, and each of the practices that we're working with has managed to do that very well. So that's the sort of quantum of time that you're talking about, and also some time which is really important to make time to discuss those results. So I think if these measurements are rolled out, we need to make sure the practice meets together, and that's what we're doing in our pilots, feeding the results back to the GPs in their practice meeting usually, and getting them to look at their own performance and also the performance of their peers in the practice, and then give them some sort of local benchmark that they can actually look at and as you were saying earlier, aspire to, and all the change theory that we were hearing earlier could come into play once they know where they're at.
So on one side we've got the fact that it's perhaps 1 or 2 hours a month. That sounds quite practical. On the other side, you've got this feedback issue, and I've got this imagination in my mind, or I'm imagining a group of doctors, and you're feeding it back, and how do they cope with it? And one of them's a little bit further out than the others.
Yeah, I mean, I suppose doctors get us whole feedback from a whole load of areas, and GPs, I guess, and I was quite used to being at one end of the spectrum or at the other, depending, to be fair, on what you measure. So I think GPs are pretty good at dealing with that, but I think it's very important to giving them the opportunity to discuss it in a confidential situation with their peers, because they often, when they're reflecting on their own continuity, there are lots of other things that come into play. As we were saying earlier, you'd expect GP trainers to get less continuity because the registrar will be seeing them. Locum use, sickness, etc., all the things we were discussing earlier come into play. So you just need to feed it back. And often, even with GPs who perhaps don't buy into continuity, if you're talking about it, explaining the evidence like we have been doing, then you can actually, usually they've all engaged, and then they go forward with their, with the whole process and looking at their own figures and just using the figures as a facilitatory tool to reflect on. Really, that's what we like to do.
Yeah, because it's a challenging environment where we as GPs are getting measuring lots of different ways.
Yeah.
But I think the difference here is it's a measurement that actually will make a difference.
Indeed.
It actually does have an impact on morbidity and mortality and admission rate and things like that. So it's worthwhile from that point of view. I don't think we've got any other questions at the moment, but do keep sending them in if you're able to. Just remember, on the right-hand side of your screen, that chat box there, do write in there. And the best way of presenting these results, we've talked a little bit about it already. You've shown us the graphs. You've talked about the fact that you have the GPs in a sort of more confidential environment. But is there any other things that you might want to say about that? Yeah,
well, as you can see from the slides I've been presenting, we've done a mixture of graphical representation, but also the actual figures. I don't know. It depends what type of personality you are, whether you take information in a figurative form or in the data form. So we give both to the practices, but most importantly, we give them an opportunity to ask us questions. Well, what does this mean, and what does it mean for me? I think those are the important things. What does it mean for our practice? So yes, and we don't we don't give them information from any of the other practices, although we will give them we could give them anonymised figures for the other practices, because what's achievable in one practice, as we were hearing earlier, may not be achievable in all practices, but they could all aspire to increase their continuity, which we found with all of our pilot sites.
Yeah. So I think that's the message there, isn't it? We can aspire to increase our continuity and to do that. And I'm hoping that people who are listening really see that how important it is, how they can do it, and how they can aspire and prove that they've done it. So that's really good. I think it's well done to all the teams in our programmes. Thank you very much to you, Phil Evans, and thank you to Sir Dennis Gray for coming along. Thank you to Joe Knight and of course Hannah, who was at the start. But it's been very useful. I've learnt a lot through this programme and really enjoyed today. So thank you very much indeed. Are there any other questions? We can deal with them afterwards, so do keep sending them in, and we will be doing a little bit more question and filming, which will add to the webinars. You can see the webinar online. You can see sections of it if you wish to. And don't forget, on the RCGP website, you've got a toolkit that you can access, and you've got the continuity community that you can enter and join. You just send an email in to the website, and we'll put you on there. So thank you very much indeed. I hope you've enjoyed that. And we'll look forward to the next webinar, which will be in December 2020 with the rest of the team, I think. Thank you.